It's my pleasure to introduce Amanda Bradley, Coordinator of Children by Choice, who will be discussing the intersection between unintended pregnancy and violence. Thank you, Amanda.
Hello, welcome. It's the first time I've done a webinar, so bear with me as well. I think Lauren's given us a bit of background around the technology we're working with. We've had a couple of practices, so we're feeling confident. So yes, I'm going to talk about unintended pregnancy and violence, relationships, options and practice. And I know Lauren sent out a little bit of a survey monkey to the participants to try and get a gauge of how much knowledge you've already got, so that I could pitch what I'm going to talk about to make sure that I'm not, teaching you to suck eggs, so to speak. The knowledge scope is quite broad, so some of you may feel like you already know some of this stuff, and I don't want to try and dwell too much on the real basic stuff. So if you've got questions or if you want more information, if you feel like I should have delved in something a bit deeper, feel free to ask questions. I can link you to a massive load of research and other resources if you're interested. Right, so just a little bit of background about Children by Choice. So we were established in 1972. We've got a long history of supporting women with unplanned pregnancies. We've got three main areas of activity. We provide a counselling service, which is funded statewide by the Department of Communities. 90% of that counselling is delivered by the phone. We do a little bit of face-to-face counselling as well. Obviously, you have to be based in Brisbane or visiting Brisbane to access that service, and we're in Windsor, not far from the city. We do a lot of information provision as part of that counselling service, so women often just want information around an unplanned or unintended pregnancy, and that's what the evidence says as well. So when you ask women what they need to be able to make a decision around an unintended pregnancy, they say information. They don't necessarily want counselling. So a lot of the work that we deliver is just information. And our website is incredibly popular. We've had about a 70% growth in the last few years of hits on our website of longer than 3 minutes. So we're making sure we're not getting people that have just gone to the website by mistake. But yeah, there's a massive load of information on our website. So we do decision-making counselling, and that's about a quarter of our work. So women who aren't sure, they're feeling ambivalent, or they're not sure how their values sit with the decisions they're making. So we do a fair amount of that as well. The other part of our work is referrals onto other services. That includes domestic violence and sexual violence supports services, legal aid, for example, mental health services, youth parenting services, and of course abortion clinics. We also do quite a lot of client advocacy, and for our clients who report violence, advocacy is a reasonable, considerable amount of our work. So sometimes they need more intensive support to get access to the support, the other support services that they need. So for example, that might be access to a public hospital for a termination of pregnancy, which is a very complex process in Queensland at the moment. So that's one chunk of the work that we do. The other part is education and training. So today is an example of some of the training that we do. We also do sexuality education with youth services. We tend not to deliver straight sex education with young people because of the evidence shows that that's not particularly effective. We do training to health and community workers, which is a growing part of our work, and then we also do a lot of resource development to inform women with unplanned pregnancies about their options, and also the people that support them. So that might be people working in the domestic violence sector like yourselves, or it might be clinicians, GPs, nurses. So there's a very wide scope of people that we work with. So that's the second part of our work. The third part is changing the legal and policy framework of abortion provision in Queensland, and that was the original purpose of the organisation. And really the education and training and counselling services have fallen out of a lack of good quality access to services for women. So we offer advice to policymakers, we conduct and disseminate research and evidence, and we publish position statements on certain issues, and we make submissions to government, both federal and state, and we also have a voice in the media to ensure that there's accurate information available for women and the general public. So, did I skip a slide by accident? Excuse me. No, I haven't. We're good. Okay. So, unintended pregnancy. I think this is a really clear to get a definition about what we're talking about when we talk about unintended pregnancy, and the research is very blurry around this because different research over different years has used different measures. So, generally speaking, an unintended pregnancy is one that was either mistimed or unwanted. So, and that's about half of all pregnancies in most developed countries, and Australia fits in that kind of comparison as well. So about half of all women who fall pregnant would describe their pregnancy as mistimed or unwanted. So if a woman did not want to become pregnant at the time of the pregnancy occurred but did want to become pregnant at some point in the future, the pregnancy is considered mistimed. And some research will delve into that a bit further and say a pregnancy is mistimed if it's 2 years. So they have a measure, I wanted to get pregnant at some point within the next 2 years or some point after the next 2 years. And that's a real, big difference, for example, for a 16-year-old. Yeah, I wanted to get pregnant. I'm intending to be a parent, but not within the next 2 years. So that would be a mistimed pregnancy. And particularly, we take into consideration the man involved in the pregnancy. So if a woman did not want to become pregnant then or at any time in the future, the pregnancy is considered unwanted. And that's about 20% of those of pregnancies. So about 30% of pregnancies are mistimed and about 20% are unwanted. Now the man involved in the pregnancy plays a big role in a woman's desire to parent, and I'll talk a bit more about that later on. But so sometimes those unwanted pregnancies are, I didn't intend to parent with this man. So another bit of a picture to take and consideration to take into the picture is that contraception fails. I think the wider public have a real belief that women who don't want to get pregnant don't have to fall pregnant. And women that do fall pregnant and it wasn't intended, well, they're a bit silly. They weren't careful enough, and it's, and women tell us that story. So women, when they voice their thinking around this, they'll use words like, I was stupid, I can't believe this happened to me, I should have been more careful. So the blame very much sits with the woman around this thing. But what we know is contraception fails. No contraception method is 100%, and we forget that. The least reliable forms of contraception are the most used in Australia. So long-acting reversible contraceptions, which include the IUDs, both the hormone IUDs and the non-hormone, the copper IUDs, and the under the skin hormone slow release, for example, the Implanon. They're used by about 10% of women in Australia, which is much, much lower than most other developed countries in the world. And there's a growing thinking that long-acting reversible contraceptions are the way of the future. Women who are very fertile, very sexually active, usually in their 20s, are the women that most often have unintended pregnancies. I think this is a misconception that teenage pregnancy is a massive issue in Australia. Teenage pregnancy rates are dropping and have been for many years. Most women that we see are in that 18 to 24 kind of age group. So this is a bit of a myth that if you're careful enough it won't happen to you, but we know from our experience that about 70% of women who present to us were using some form of contraception at the time that they fell pregnant. I think this just a little reminder as well that there are negative outcomes of unintended pregnancy, and there's some really good research coming out of the US particularly around this. Women with an unintended pregnancy tend to find out that they're pregnant later. Particularly women who experience violence tend to find out that they're pregnant later. So they don't access good quality early prenatal care. They aren't expecting to be pregnant, so alcohol and drug use, tobacco use sometimes becomes an issue. The risk of STIs not being treated in a timely way, which can impact on the pregnancy. And there's some really solid evidence now saying that the health of both the mother and the baby, if the woman progresses with the pregnancy, are worse off with an unintended pregnancy compared to a planned pregnancy, which is pretty logical. So let's talk a little bit about women who experience an unintended pregnancy. So just some real basic stuff. They're more likely to experience poverty. They're more likely to have lower levels of education between 18 and 24. They're more likely to have experienced violence. Now that's a really interesting overlap. Women who experience an unintended pregnancy are more likely to have experienced violence. And there's a whole lot of thinking around why that happens, which will be very logical, but you might not have made the connection. They're more likely to experience depression. So mental health becomes a massive issue as well. The contributing factors have been lack of good quality sex education, lack of planning about parenting, so women haven't really had an opportunity to think about what it might mean to parent and think about what does it mean to parent. And they also, one of the big issues is access to good quality contraception, and that becomes a whole different ballgame, particularly in Queensland, and if you're rural and remote, live in a small community. So it's basically the overlapping nature of disadvantage and the health determinants apply to unintended pregnancy. It's one of those things that you take the social determinants and you look at unintended pregnancy, and the risk factors are straight overlap. So I've talked a little bit about social status and income, education, the physical environment as well. So, women who are in rural and remote communities are more likely to experience an unintended pregnancy. Women with not good quality social support networks. So if your social support networks are, very low, you're more likely to experience an unintended pregnancy. And your access to health services is another one, which sort of overlaps a little bit with contraception access. So I want to talk a little bit more next about violence and reproductive health. So intimate partner violence, and I'm going to do a little bit of declaration about my use of language. Because we're talking about unintended pregnancy, I'm going to talk about intimate partner violence, but just in the wider context of violence generally. Women who experience violence are more likely to experience an unintended pregnancy, but reproductive coercion is a particular act that happens between sexual partners. So I'm going to talk about it in that context. So intimate partner violence particularly puts women at a host of negative sexual and reproductive health consequences. They are more likely to have an unintended or unwanted pregnancy. They're more likely to have an abortion. They're more likely to have an unsafe abortion. And they're more likely to experience pregnancy complications if they progress with the pregnancy. So this is a chicken and egg thing. So unintended pregnancy are 2 to 3 times more likely to be associated with intimate partner violence than planned pregnancy. So I think this is a real message that we need to get across to the primary care sector, that when they have a woman who's pregnant and she potentially says this pregnancy wasn't planned, I think there should be a screening, part of a screening for intimate partner violence. I don't know if we're quite there yet with the research and the evidence, but it's certainly something that I think should be considered. So we've got a submission that we did on, I just wanted to find it so I could talk through some of that. Here we go. So let's go to the next slide. So I want to talk in a bit more detail about reproductive coercion and how that presents itself. And I like to talk about a continuum of reproductive coercion. So at the low end of, I'll call it offending, it will sound like things like, if you love me, you'll have my baby, or vice versa, if you love me, you'll have a termination, through to rape, obviously, at the extreme end and extreme violence. But it's a range of male partner pregnancy controlling behaviours. So we see birth control sabotage quite a lot, and that can happen in a wide range of situations. Holes in condoms. I think the classic ones that we see is condoms slipping, or him taking the condom off during sex. So she thinking that everything's going to be fine, he's wearing a condom, and then him removing the condom during sex. So that's one of the more common kind of behaviours that we see. Obviously for sex. Refusal to use condoms or refusal to use birth control, contraception. The last bullet point I've got on there is the prevention from obtaining birth control, and this is a little bit more interesting because this is where the more insidious control kind of behaviours with women and men involved in the pregnancies tend to happen. So he might come to her GP appointments with her. He might not, you know, let her fill out prescriptions. He might do things like, you know, if you love me, you wouldn't take the pill. So there's the whole control of contraception is a really interesting dynamic that happens in intimate partner relationships where we're talking about reproductive coercion. The other classic one is withdrawal. I forgot about that. So saying, I'm going to withdraw, I'll withdraw, it'll be all right, and then not. And we've also had the classic, I've had a vasectomy, or I'm infertile. They are the classic phrases that we hear women report, like the man involved in pregnancy told me that he'd had a vasectomy. And then, so that's obviously leading up to conception. Then once the woman's found out that she's pregnant, some of the other barriers that the man involved in the pregnancy will use are things like, she'll say, I think it's best if I have a termination, and he'll say, I'm not paying for it, or I'm not going to support you if you do that. And then vice versa, I will pay for it. So we've had stories of women who, the man involved in the pregnancy says, I'll pay for it. She presents to a clinic and then he refuses to pay for it. Then there's the threats to end the pregnancy, or to end the relationship, or to, you know, whether or not she has a termination. So if you have a termination, that's the end of the relationship, or if you don't have a termination. Sorry, if you progressive parenting. So that's flip side is a common conversation that we hear. So just a little bit about our data. I'm just going to see if it's in the next slide before I progress. Yeah. So this is a little bit about our data that we see. In the 12 months ending June 2014, about 17% of women reported violence. Now that's escalated again. So that was it had increased quite considerably over the last couple of years and continuing to increase. The last 2 months of data, so we're talking January and February, we've seen about 40% of women presenting to us who disclose violence of some kind. The 6 months to July to December was looking about 30%. So we're seeing this very quick escalation over the last couple of years around the numbers of women reporting violence who use our service. I know that domestic violence services have also been experienced this increase. I guess the conversation is why, and I'm sure you guys will have your own interpretation about that. My feeling is that it's twofold, partly about service reductions and generally in the community sector, so women are having fewer and fewer places to go to, and the hardship that women are particularly experiencing at the moment with the economic climate. And also potentially there is a lot of conversation in the media about what domestic violence looks like, and women potentially in the past who might not have considered a particular behaviour as a part of the picture of domestic violence are going, beginning to identify that. So they're going, okay, what he's doing is considered domestic violence, and she's more willing to have that conversation. I think that's part of the picture. So the women that use our service who experience violence are more likely to describe their relationship as separated. So quite often women are coming to us when they're escaping the violence, and that has risks in itself, which I'm sure you're very familiar with. Aboriginal and Torres Strait Island women are more likely to report violence, that use our service are more likely to report violence. They're much less likely to report to our service early in their pregnancy. I've got a bit of a... So of all our contacts, when they come to us that are under 6 weeks gestation, there's about 23%. The women that report violence, it's about 7%. If we get up to the 6 to 11 weeks, it's 40% versus 37%, but when we get up to 12 weeks, it goes 10%, 19%. So we're really concerned that women who experience or report violence have that dynamic of A, finding out that they're pregnant potentially later, and B, seeking support, having the ability to seek support potentially later in the pregnancy as well. The last disturbing little note there is that 42% of women who reported violence to us also reported trying or contemplating self-abortion. So we've only just started accurately collecting self-abortion reporting data. For a year we've been doing it. And that was because the numbers seemed anecdotally to be increasing. It used to be quite a rare conversation, and we started to think that it was happening more often, so we were really interested in that conversation. And yeah, women become very desperate, and they will do whatever they believe they need to do to access a termination if that's their decision, or if they see that as being their only decision or their only option. Quite a few of you expressed a real interest in finding out a bit more about our best practice options counselling. I'm not a counsellor, I'm not a social worker, so I can't speak to this in great length, but I have given Lauren a series of resources that we have, and I'll talk through some of the key points that we use, so kind of some of the key frameworks that we use, and Lauren will pass on the resources. So I think there's 3 core principles that I've got on that PowerPoint slide. So the commitment to the principle of reproductive autonomy, and I'll talk about this in a little bit more. I'll talk about each point in a little bit more detail. So our counsellors come from the framework that women can make a decision about her reproductive autonomy, and that we're okay with that. So we come from a real non-biased, non-judgmental framework. So the woman's decision is the right decision for her, and if she makes the choice to have a termination, you know, we can't put our own value set on that woman's choice. So as part of that, we've got a very strong commitment to evidence-based practice in medicine and health advice. So we're very conscious that we need to be up to date with our health advice around particularly abortion provision, since it's a medical procedure, and making sure that we give that advice accurately and unbiased without judgment. We spend quite a bit of time debunking myths about abortion provision, both in the media and with women who are our clients. So we're very conscious that women often come to us with ideas that they have about abortion, even from a very basic health perspective, that might not be true. And I can give a very simple example about that, and that's abortion and breast cancer. So women might say, I've heard that abortion puts me at greater risk of breast cancer. And we have to be very clear that, the Breast Cancer Foundation are very clear, the Public Health Association are very clear, the Association of Medicine Australia is very clear there is no link between abortion and breast cancer risk. So some of these myths get perpetuated in the media and by certain lobby groups. That we've got to be cautious that we're making sure that women get accurate information. There's also, our counsellors often talk about their own values and separating their own values around the options that women talk through. So how do I feel about adoption? How do I feel about abortion? How do I feel about parenting, particularly for young women who might be deciding to parent? And with abortion, I think, there's always the scope within the abortion conversation about how do I feel about a woman who might make a decision to have an abortion at 16 weeks, for example. So trying to be really clear about our own belief systems and value sets, and making sure that we separate those from the counselling that's provided. So the second point up there is, hold on, I just want to talk a little bit about language, my mistake. So you might have noticed I use, and I don't know how familiar you are with this kind of stuff, I use terms, the man involved in the pregnancy. So that's one of the things that we really avoid, is presuming that there's any relationship between the man involved in the pregnancy and the woman who's pregnant. So we never presume. I think that's one of the things that we're very clear about. We're also very clear about good decisions and bad decisions, or best decisions. So we tend to move away from right or wrong, and go back to what is the best decision for the woman in her circumstance. We had the privilege of showing a documentary called After Tiller last week as part of our conference that we held, and one of the abortion providers, one of the doctors in that, said very clearly that she was talking about a very young woman who had a pregnancy, who was Catholic, and her values didn't sit very well with abortion, but she saw that as her best option. And the abortion doctor said something along the lines of, she's got three choices. She can have a termination of pregnancy, she can parent, or she can choose to adopt. And she said all of those situations are shit situations, and none of them are great, and she's got to choose what she thinks is best for her out of those three situations, which I thought was a really good summary of a lot of women that we see. None of the choices are good, and they're making a choice that is best for them at that time. So the other thing that we do is we avoid using the word or referring to the pregnancy as a baby. So we use the term the pregnancy. So how are you feeling about the pregnancy? How many weeks is the pregnancy? How many weeks gestation is the pregnancy? So we don't refer to the baby. This lets the woman, sometimes women will refer to the pregnancy as baby, which is fine, that's up to them. But we try not to put any of that values-laden language into our conversations with women. So I think they're just some practical tips around language when you're talking with women. The personal is political. I think I won't go into this too much. I did a presentation last night and I said you shouldn't talk to your friends about politics or religion. I'm going to do both. It's very hard to have a conversation about abortion provision without unintended pregnancy without talking about the politics of abortion, unfortunately. Just a note that in Queensland, abortion remains in the criminal code. There is case law that allows women to seek and have a termination of pregnancy if the pregnancy endangers her health, including her mental health, and social and economic factors can be taken into that. And I'll talk about the guidelines for provision of termination of pregnancy as well a little bit later. But we know we lived in there's a gender discourse around women's reproductive health, and it's got a long history. Women who have particular religious views seek our services. We meet the needs of women across a wide variety of religious practices and belief systems, and I think it's just interesting to remember that we've got that that women come with their values and belief systems, and that the decision will be made within that framework. And the final point is the woman is the expert in her own life, and we use a woman-centered approach, which I'm sure most of you are very, very familiar with. That last question up there I thought is a good one when you're in practice that you might be able to use. When you potentially have a woman that you're addressing the needs of who announces or lets you know that she's pregnant. It's just a simple question really, is how are you feeling about the pregnancy? And that gives her an opportunity to say, you know, where she's at with things. Just a practical tool. I've got a few case studies in here. I've got a couple of parenting case studies, and I've got a termination case study later. When I talked to the counsellors, the counselling team about these case studies, they found it really complicated to present some case studies that had any kind of positive outcome. We often lose touch with women once, so we're very much a short-term service. We do repeat counselling services for women, and we often lose track with women, and particularly if they've reported violence. You know, they could move states, move cities, change their phones, and we find it quite difficult to find out what has happened. But this one's a woman in her early 20s. You can read it, from a small rural town. So she was brought in by the man involved in the pregnancy. So he was considerably older than her, well educated, well placed financially. The counsellor said that it was very clear that he held the power in the relationship. So just as a best practice with our counselling, so that the counsellor will always see the woman by herself. It's a bit trickier to do by phone, but we often we're very mindful that women might not be in a safe place to speak when they're on the phone, but definitely when they're in a face-to-face counselling session, they get as much time as they need by themselves. And if they don't want the support person or the man involved in the pregnancy to come to the counselling session, that wouldn't happen. If she feels like she needs some guidance with having that conversation with the man involved in the pregnancy, we're very happy to help her navigate that. So she was very clear that she wanted to parent. She had very clear moral and ethical belief system that said abortion was wrong for her, and so she was clear that she wanted to parent. So he started the conversation by saying, you know, if you ended the pregnancy, we could have a great life together, we could travel the world, we'd be independent, we wouldn't be tied down. So it starts off as quite gentle coercion. And then by the end of the conversation, and he was starting to realise that she definitely wanted to parent and she wasn't going to budge on that, that he was going to involve child safety, he was going to get the child taken off from her, he was going to employ lawyers, and there was no way that she was going to have custody of that child. It was a very disheartening conversation for the counsellor involved. We had some time with her by herself and said that she needed to seek professional legal advice, and we've supported her to do that. So this is, I'll just go over this very quickly because we're getting short of time. So this is a 16-year-old that was in the care of child safety. So she was brought to us by child safety to have decision-making counselling. So her situation wasn't particularly stable. She really felt that she had a chance to break the cycle of violence, and that she had a better chance than her mother had had of doing that. So she made the call that she was going to parent, even though that she was in care with child safety herself, and that she had been, the department was managing her contact with the man involved in the pregnancy because of his violence. So quite disheartening, really. So one of the documents that I've shared with Lauren that you'll have access to is a blueprint for access to abortion. I think the key things to note are abortion providers are mostly in the southeast corner of Queensland, so if you're in Brisbane you've got pretty good access. If you're outside of Brisbane it gets a whole lot more complicated. Townsville, Rockhampton, Cairns. So if you don't live near those centres you're going to have to travel to those centres. 99% of abortions are provided in private clinics. That costs money. It starts at about $400 if you're in Brisbane and about $600–700 if you're not in Brisbane. It escalates very quickly once you get over 11 weeks gestation. So you end up in the thousands of dollars. The thing about that for women who report violence is A, they often have very little income or no income. They often don't, they're reporting later in their pregnancy, so this puts them at real risk of not being able to access a termination. We do provide some financial support, and we often brokerage with other supporting organisations, and we're keen to work with domestic violence and sexual assault services to ensure that women have access to termination if that's their choice. So we can help them work through how they might find the money. In that document, the Blueprint for Access, some of that is talked about how we support women to find money, and it's absolutely anybody could do that as well. There's no reason why a DV support worker or a social worker or any other counsellor couldn't help women work through that process. And we also help women negotiate access to public provision in their hospitals. That is a fraught process, unfortunately. We'd love to see that improve. There's a little bit of a case study there about a woman who accessed a termination. One of the things that we find is that women often see a termination as part of their safety planning, which might sound strange, but women see, particularly if they haven't got any other children with the man involved in the pregnancy, they'll see that as, I'm getting out of this relationship. If I have a child with this man, that's going to tie me to him. I do not want any ties to him. If I have a termination, it helps me get out of this relationship. So that's just a bit of a heads up around and that. I'll let you guys read that yourselves. So just to finish up and talk a little bit about some of our other services. We've got young women are particularly vulnerable. We've had some private funding recently to develop a resource for young women who wanted to access advice about unplanned pregnancy and contraception, and we've called it Know For Sure. That's the website there. So one of the things that we thought young women weren't presenting to our service early was because they didn't know they were pregnant, but what we found out when we did some research was they absolutely knew they were pregnant, but they thought it might go away. So they tend to do the, monkey see, no, it's not going to happen to me. But also there's a strong belief that they will have a miscarriage. So they see miscarriages, well, lots of women have miscarriages, that will happen to me. So there's a lot of myths around pregnancy for young women that we've done some myth busting about. Some of this resource talks about having safe conversations, how to tell your parents, how to tell the man involved in the pregnancy. Who should I disclose the information to? Who's a good person? And also vice versa, when somebody discloses this information to you, how can you best support that person to access services? So we see it as a really good resource if you're working with young people particularly. And just finally, our website is acting as a first port of call for information. Lots of people ring our service, and we can ask, if they'd looked at our website, the answer was pretty much there, which takes up quite a lot of our resource. So we definitely like people to look at the website first. Absolute ton of information there for women making decisions and for any kind of support worker that might be supporting them to do that. So yeah, I guess this is the point at which we come to questions.
Firstly, they're wanting to know the rates around unwanted pregnancy or unintended pregnancy through rape.
Yeah. I don't know the answer to that question off the top of my head. It's something that I'd have to investigate with. And it might not even be a very clear, I don't know if the data would even be very clear. The unintended pregnancy data is very, very murky. And I don't know if it will go down to that level of accuracy. I don't think there'd be anything in Queensland. I'd be surprised if there was information for Australia, but there probably would be for the US, which has got quite a different kind of picture as well around unintended pregnancy. So I can try and have a look and see if I can find something. I'll write myself a note just in case there is.
And I have the contact details for that person, so I can pass them on to you. For those people that came in a little bit later, I just mentioned at the beginning that if you have questions on the grey panel to your right-hand side of your screen, you can type in questions and I can feed them to Amanda. So if anyone came in late and have questions, please type away. That same person also wanted to know about services available to these, if there are services available to these women who have experienced unwanted pregnancy through rape for women and youth for termination. So I suppose you sort of answered that a little bit regarding the abortion clinics.
Yeah, absolutely. I mean, that's something that we'd support women with. So we can support them with counselling and we can support them with access. I think I didn't talk too much about access, and I actually didn't end up mentioning the public hospital guidelines. So Queensland Health 2 years ago now published a document called the Therapeutic Termination of Pregnancy Guideline. It's a great document. It's a very, very evidence-based. It sits within the current legislative framework in Queensland, and it basically guides clinicians in public hospitals, including social workers, for example, of how women might be able to access a termination, and talks through the circumstances in which a woman might access a termination and the clinical, as well as the clinical guideline stuff. And it's online. If you just Google Therapeutic Termination of Pregnancy Queensland Health, it'll come up, which will give you a guide, a bit of a picture around what that looks like. For example, we had a young woman maybe about a year ago now who was a visitor to our country. She had been the victim of a rape by somebody she knew who was an Australian citizen, but because she was not a citizen and didn't have any residency rights and was visiting, I think she was here with her family while her parents were on a work visa, she was not able to access private clinic. Prices were just absolutely horrendous. Because she was young, so she's still a child, we supported her to access a termination through a public hospital. It's quite a complex process, which means that you're later in the pregnancy, which means you've got all that waiting around, and you're very clear on what your decision is. It's quite traumatic. but her family had to pay close to about $3,000 for that procedure, so which they didn't have. So between ourselves and another service, we paid for the procedure and then recouped the expenses through the Victims Assist program. But because that process takes so long and you need the money now, not in 6 months' time, women who experience rape often find that it's
not good enough.
It's not an ideal situation. Yeah, we get really upset when we're supporting women in that situation. It's not pleasant. We wish it was better. We wish we could do more to advocate for women in that situation so they didn't have to negotiate such a fraught system.
Okay. So I've actually got a few questions or comments coming through about the funding and financial assistance. So there's one asking about funding or travel for women who are unable to fund the abortion due to personal situations, which you've sort of answered.
Yeah.
And another one...
Travel come out of the travel subsidy scheme. So when we're supporting, it gets gate-kept. This is one of the issues. So the administrator on the end of the phone that runs the travel subsidy scheme in whatever hospital or health service that woman is accessing can say, we don't provide travel for that procedure, which they do. If you get told that, they do. They're being bad. So we get blocked sometimes by people's value sets.
Mm-hmm. Another comment, in the UK, women can have a termination free of cost as part of the health system. Are there any exemptions for fees in Australia, or is it the case that all women pay regardless of their financial circumstances?
Okay, so Queensland is a bit unique. We are the only state that has such a massive disparity between public and private provision, partly to do with our laws, partly to do with a very conservative health system. Because of the law, you doctors are fearful of being sued. People may be familiar with the Cairns case back in 2009, I think it was, where a young woman was prosecuted and her partner were prosecuted. Went to court. They weren't found guilty. It's the Cairns case. But 99% of procedures in Queensland are provided in the private care. In South Australia, that's exactly the opposite. So 99% are provided in the public health system and 1% are provided in the public system. We've got some serious work to do in Queensland to make sure that women who experience disadvantage can get access to support services of their choosing. It's not very equitable. It creates massive health inequalities for women who've got all sorts of disadvantage in their lives. I could rant.
Yep. Next question or comment. Working in a shelter, I realise more and more that violent men use rape as a weapon of choice, anecdotal evidence only. Is reproductive coercion too soft a term?
Yeah, it's interesting, eh? I've got a couple of documents that I could send out to people if they're interested on how reproductive coercion is defined. I guess it's a very broad, overarching term for a whole lot of behaviours that sit under it, and at the extreme end it is rape, and an intimate partner relationship that could be happening every day. It could be incredibly traumatic. There is this lower end of reproductive coercion as well, where it is this how a man has conversations with his sexual partner about contraception, about parenting, about how sexy she would be if she was pregnant, all sorts of things like that. So it is a soft term, I agree, but I think it's the overarching term of a whole lot of behaviours that fall out under that term. But I'm happy to send out some links to some. So we've done a bit of a literature review on the use of language around reproductive coercion, which I can send out.
I was wondering about if a lot of so do you see more women that experiencing violence and then fall pregnant, or if the violence started after the pregnancy, and that then becomes an unintended or an unwanted pregnancy?
Yeah, if anyone attended our reproductive coercion event last year, we had a bit of a conversation around this, and there were a couple of researchers there. Anyway, she talked about, so there's some research that says that pregnancy can be a trigger point and that violence can escalate, but conversely it can also de-escalate. So a woman who's been experiencing violence who falls pregnant can suddenly find that the violence, de-escalates somewhat. And what some of the thinking around that is that it becomes a control. A woman who's pregnant is controlled. So the controlling behaviour of the man involved shifts. I've got you now. So that there can be that part of the picture, or conversely, women experience violence for the first time in pregnancy, which is well documented as well. So I think that it's a broad spectrum of behaviours, and we see both.
Okay, well that's all the questions I've got so far. Does anyone else have any questions, any more practical tips? I thought that was great around the language.
Sorry, for supporting women who are reporting violence, and for us as an organisation, particularly around pregnancy, is an awareness that pregnancy can be part of the picture of the violence, and that women might not disclose that, and that they might have not have even considered the fact that that's part of the picture. Women who experience violence sometimes have 6, 7, 8 children in tow, and reproductive coercion may be a factor in that, and the reason that that's the situation she is in. It's worthwhile having the conversation with a woman who's pregnant. How are you feeling about the pregnancy? And being mindful that it might not have been intended on her part. So.
Okay, well, I think that's about it. So thank you very much, Amanda. Oh, there's one more, sorry.
Slip in a last quick question.
Oh, there's a few. They're all rushing in before you duck off. Recently I've heard a lot of myths around contraception, i.e. the IUD causes you to have an abortion each time you're pregnant.
Yep. IUDs do not prevent, they're not an abortion. So there's a really interesting debate by the pro-life movement around when conception happens and when life starts. And so the morning after pill is considered an abortion, even though we could argue that far from the fact that it is. So IUDs prevent an egg embedding into the wall of the uterus. So even if the egg has been fertilized, it's not embedding, it's not by any stretch of the imagination an abortion, and I don't think there'd be any medical professional that would argue that. I think it's the moral debate around when life starts, and we could have that debate forever, and there potentially isn't a right or wrong answer.
Okay. The person that asked that question asked, what can you say to this? Was that, can they just let me know if that was answered? Do you feel that was answered? In the meantime, someone is very interested in getting more information about youth and sexual health and how that's not working.
Okay. Yep.
Yep.
I know that Family Planning Queensland are holding an event upcoming in Brisbane around sex ed as violence prevention, which I'm going to attend. I'm not presenting, but I thought that's an interesting conversation that we should be having. Sexuality education as part of, school from a young age should be about healthy relationships and what a healthy relationship looks like, and how we treat each other, how we how we can have conflict in relationships without having violence. And I think that's a really interesting space to be in at the moment. I think Queensland's lagging, unfortunately, but there's some really good research around it. One-off you know, us going into a school talking to 300 kids makes no difference. So it's pointless in doing it, and I try to explain that to school-based nurses who want us to do that kind of work, or principals. It doesn't make any difference. You're not going to change young people's behaviour in 30 minutes.
Is there any specific training provided to midwives and other hospital staff in relation to first contact identification of DB? And if so, how intensive is the training? And
I don't know it. No, I don't know who provides it. I don't know how much midwifery training focuses on violence at all. I went to a meeting last night with the perimental health team, and there were quite a few midwives there, and there's quite a few midwives came to our conference as well. I think there's a growing awareness in midwifery practice. Kathleen Beard is the name of the researcher. I've just remembered that she was the one that spoke at our, talked about pregnancy being the trigger point and the control point when there's violence involved in a relationship. But I think Kathleen Beard is doing some research around this very thing at Gold Coast Hospital, which I can potentially send you her contact details.